Welcome to Pain Assessment, Advanced 1. This module focuses on the basics of pain assessment in older adults, important for all nurses who are responsible for assessing residents and documenting their pain issues. The objectives are to talk about some of the core principles of pain assessment, what needs to be included, what those components are, to describe each component with evidence-based information, to describe 3 pain assessment tools that you could use in your facility with residents who can self-report, and to describe 2 pain assessment tools that can be used with residents who are not able to self-report. Some core principles that should be considered in thinking about pain assessment in older people. One is that older adults have the right to an appropriate assessment and management of pain. This is a key principle that needs to be accepted and committed to by the organization. Another core principle is that self-report of pain is the single most reliable indicator of pain. Many may not believe this, but key organizations that have developed consensus documents about pain acknowledge that it is the individual who must describe what pain is to them, the severity of pain to them, if they can self-report. Other indicators, such as physiological and behavioral signs of pain, can contribute to understanding of pain, but neither are sensitive or specific for pain. Thus they can represent other problems, and so should not be relied on as a key decision point about whether or not pain is present. What the person says is pain is more key. Assessment approaches, including tools, need to be appropriate for the older adult. Thus, we're going to talk about ones that are valid and reliable for use with older patients. And finally, pain can exist even when no physical cause can be found. Thus, it's not appropriate to dismiss a pain problem just because there may not be a diagnosis or a physical condition causing pain. We know chronic pain in particular can occur without having the presence of a physical cause. Some other core principles. A uniform pain threshold, meaning when or how severe a pain needs to be felt, does not exist. Pain is variable. Pain tolerance varies from person to person based on their heredity, their energy, their prior coping skills, their prior experiences with pain. Thus, we can't say for every individual how much pain is felt before pain is identified, or how much pain should be experienced before a person says it's severe. The bottom line is pain is individual, and what the patient tells us is what we must operate on. A third principle is that older adults with chronic pain may be more sensitive to pain and other stimuli. Their resources and ability to cope with pain may be reduced, and so pain may seem more severe to them. Unrelieved pain can have adverse physical and psychological consequences, and we are aware of many impacts from unrecognized and untreated pain. It can impair rehabilitation, it can impair eating, sleeping habits, it can impact with ability to interact in social activities and communications and interactions with others, it can have a serious impairment on immune function, and untreated acute pain can turn into chronic pain and long-term problems. Thus, recognizing pain and treating it effectively is a priority. And finally, pain can be both sensory and emotional, and so assessment needs to be comprehensive. Margo McCaffrey phrased a coin many years ago that pain is anything the patient says it is, and we now accept this, and it explains our position about self-report being the best source of information. So we have to believe what the patient's telling us, do a thorough assessment, and treat pain when pain is reported. What is pain? Well, we evaluate residents to determine if they have pain, and if so, how severe it is, and what are the characteristics of that pain, because all of these elements are important for us in determining what the treatment plan should be. It includes the resident's self-report, if possible, a physical examination, observation of behaviors, reports from others who know the resident well, such as the CNAs in the facility or other team members, and medical diagnoses that we know are painful, or recent trauma or injury that could be causing pain. Assessment methods that we use to gather information about pain in older people need to be appropriate for the older person. We also have to take into consideration aging changes such as hearing impairment, visual changes or loss, changes in cognitive function that can impact their ability to self-report and use tools that are appropriate for sharing information about pain. So making sure we have adaptation devices in place and that we adapt our tools to be appropriate for those with visual impairment or hearing impairment or cognitive impairment. Family members are also important sources of information, as well as CNAs and other members in the or workers in the facility who are familiar with the person and can help contribute information to the assessment process. When should pain be assessed? Well, MDS standards include assessment at admission, anytime there's a change in status, anytime pain is suspected, and at least quarterly. And these would be minimums that will keep us regularly monitoring and evaluating for the possibility of pain in our residents so that we can be assertive and aggressive in getting effective treatment. There are many challenges to pain assessment that we need to think about when we're gathering information. Many older people don't want to be complainers. They may be stoic and they may not be forthcoming with pain problems. They may be fearful about procedures, side effects that may occur from treatments, being institutionalized in an acute care facility, and so may be reluctant to report pain. Many older people feel that pain is a part of aging and thus has to be accepted, and so may also not report pain problems. There are many cultural differences that we need to be aware of depending on the patients that we treat in our facilities, but there are cultural aspects about treating pain and about reporting pain that we need to be sensitive to. As I mentioned, cognitive and sensory impairment can impact their ability to recognize pain in older people. Depression is a common problem in people that have pain. Over 30% of people with chronic pain also have depression, and it may be confused, so we need to assess both. There are also multiple causes of pain that need to be considered, and many residents may have more than one pain problem that needs to be treated. And concurrent illnesses are important and challenging. Many treatments can either be inappropriate or appropriate based on comorbidities such as cardiac disease, liver disease, kidney disease. So being aware of those are important when we're thinking about what the treatment plan needs to be. The key components of a pain assessment are these, and they need to be assessed and documented when a patient has pain. Pain intensity, pain location, pain character, pain pattern, and pain impact on function. We're going to talk about each one a little bit. Pain intensity. Pain intensity we gather from the patient when we can, or the resident when we can, and this is how bad the pain feels. How severe is the pain? We ask residents that can self-report to share that information with us through scales that are approved for use with older patients. One is the numeric rating scale, which is a 0 to 10 scale, where 0 is no pain, 10 is the worst pain possible, or most severe pain possible. And we ask the resident to identify on the scale how severe their pain is. Another approach that works well is a verbal descriptor scale, and many older people prefer that scale. It is a tool that shows words, or that we ask words in categories such as none, mild, moderate, or severe. For residents that can't self-report, there are behavioral scales that we can use to document presence of pain, or at least the potential likelihood of pain for follow-up assessment and evaluation. These tools document behaviors and degree of behaviors that are observed by either family or caregivers who know the resident, or by others, depending on the timing and the use of the scale. It is very important for all residents to have baseline pain assessment, to know what their pain is on admission or when pain is first assessed, and then reevaluated with the same tool or the same approach so that we can determine if we're having an impact on improving their pain problem. It's important to find out where pain is located. Where does the resident feel pain? For example, is it in the back, upper, lower? Do they ache all over? Is pain in an elbow? Having the older person help identify the location of pain is a key strategy. So asking them to point to the pain, to tell you where they're hurting, to document on a pain map, show you where their hurt occurs, can be ways of gathering information about pain location. And again, they may have more than one pain problem, and it's important to document and get information about all sites that are hurting them. Character of pain is important because it helps to determine if pain is nerve-related or musculoskeletal related, and that helps the prescriber to determine what treatment approach is going to be best for this particular pain problem. So asking the resident that can communicate to describe their pain. What is the quality? What words do they use to tell you how it feels? And these are examples of words. The ones on the left are more typical of nerve pain: dull, aching, cramping. And on the right are words that are more typical of nerve-related pain: shooting, burning, tingling, stabbing. And you can see from the next point on the slide some differences between pain that's from muscles and bones and joints versus that's from nerves, damage to the local peripheral nerves and also in the brain, and the kinds of conditions that may cause these different pain problems. Musculoskeletal pain can be caused by arthritis, tumors, muscle strain, fractures, and how it's described: dull, aching, pressure, tender. Nerve pain can be caused by things such as diabetic neuropathy, shingles pain, conditions such as spinal stenosis, where the spinal column is impacted, can lead to different pain problems and descriptions that need different treatment. So gathering information on character is very important. Pain pattern. How does their pain show itself? Is it present most of the time or all of the time? Does it come and go? Does it only occur in the morning? Does it only occur when they engage in activity such as range of motion or physical therapy? Describing the pattern also is important because it helps impact treatment decisions. Do they need a medication that's on board all the time, or do they need a medication that is administered prior to activity that causes pain? And can we use non-drug treatments at periods when pain is likely? And finally, it's important to understand the impact of pain on function and quality of life, and gathering information and observing for changes in their activities of daily living, their ability to move, transfer, do their AM cares, their mood. Do they seem more depressed or anxious or irritable? Are they able to sleep? Or are they sleeping more or not sleeping? How is their energy level? And are they able to participate in meals, social activities in the facility that are important to them but may change if pain is a problem? So evaluating impact of function based on pain is very important as well. So assessment. Who do we assess? Well, our resident population is often divided into those that are able to self-report and those who are not able to self-report. And there are differences in approaches to assessment. If the resident can self-report, we're able to use verbal reports, some of the tools that we mentioned, even nonverbal indicators to a question about pain. A nod, a point, a blink can help us to understand through a self-report, maybe not verbal, but whether or not pain is present. For those that can't self-report, it's important to look at other strategies. And patients that may fall into this category are those who may have advanced dementia, advanced neurological disease, Parkinson's disease, for example, who are post-stroke, who are imminently dying and no longer able to communicate. The developmentally disabled or intellectually challenged may fall into this category, and those who have an acute delirium or confusion state may also not be able to self-report. So how to assess? For self-report, we mentioned that there are numeric rating scales, verbal descriptor scales, and also FACES pain scales. And I'm going to give you some examples of tools that you might consider using in your facility. This is a numeric rating scale, and it is a simple scale that needs to be presented large enough that the resident can see and read the numbers and the words. So at least a 14-point font or larger. But pain is rated from no pain to worst possible pain, and the resident selects the number that indicates their pain. We usually focus on current pain so that we don't have problems with memory issues by asking them about their worst pain or the pain before treatment. So we ask about current pain and have them rate it for us on a scale such as this. The verbal descriptor scale, operationalized sometimes as a pain thermometer, can be a good approach. This is a thermometer scale that's valid and reliable for use with older people. It includes a verbal descriptor scale or words, and it's alongside a thermometer because the thermometer helps those with cognitive deficits to understand that as temperature rises, pain increases, and they may understand what we're asking them better. And again, we simply ask the patient to pick the words that are how severe their current pain is right now. So it's a very easy approach, and most older people like to use words to describe their pain. And this is an example of a FACES rating scale, and it's a series of facial expressions, and you ask the older person to look at the faces and pick the face that represents either their current pain or their worst pain. Again, we really like to focus on pain right now, and then the tool can be scored and monitored over time. When should reassessment occur? So there's initial pain assessment on admission or when you first experience pain, but reassessment is very critical. So following up after treatment to see if the treatment has made a difference and if pain has reduced or declined to an area that or a level that's acceptable. So on a scheduled basis for residents who have reported pain, based on whatever the standard is established for your nursing home, and based on what the pain problem is and the cause of pain or the severity of pain, that may impact how often reassessment occurs. We typically plan to reevaluate pain related to when you expect the intervention to be effective. So if an IV analgesic is given, pain should be relieved within 10 to 30 minutes. Of course, this is probably not going to be used much in the nursing home facility, but it gives you an example of when timing of reassessment occurs. With PO, oral analgesics, you should see an effect 60 minutes after the medication, and it may peak sometime after that. But within an hour, it's good to reevaluate if we're having an effect. So thinking about a reasonable time interval after an activity or procedure that causes pain to see if indeed our treatment is effective and their pain is being managed. And also, anytime pain is suspected, reassessment is warranted, and regularly, quarterly, as a part of MDS continued recognition and evaluation. How should pain be reassessed? Just like the initial pain assessment. We want to follow up looking at the same characteristics and particularly following pain severity evaluations or impact on function and quality of life using the same tools or the same observation approaches that were used in initially identifying pain. And it's important to document findings so that it's easy to observe whether or not pain is improving or getting worse, and to communicate across shift and across provider what is happening with this resident and their pain problem. Why reassessment? Reassessment is as important as initial assessment. If pain is not assessed, we can't understand whether or not our treatment is being effective. So reassessment provides feedback on whether pain medications are working or whether non-drug treatments are working. It helps us to determine if new pain issues are arising, to evaluate for side effects of pain meds, to be able to monitor ongoing status of pain, and to be looking for possible pain-related behaviors in residents that are not able to self-report. So reassessment and ongoing awareness and monitoring for pain and changes in pain is an important part of assuring that our residents have pain recognized, treated, and that they have the best possible quality of life and comfort possible. Takeaway message is quality pain assessment and reassessment is the foundation for improving pain in nursing home residents. A quality pain assessment includes evaluating intensity, location, character, pattern, and pain impact on function. Pain assessments should be completed regularly with a pain tool that's appropriate for the resident. You as the nurse are the leader in your facility in ensuring quality pain assessment is completed for each of your residents, that pain is a priority, that recognizing and treating it is an important goal of your organization to assure resident comfort and high quality of life.